Disorders of the chest wall and diaphragm. A variety of chest wall and diaphragmatic disorders can lead to nocturnal hypoventilation and chronic respiratory failure, which occurs when the load placed on the respiratory muscle pump exceeds the pump's capacity. Abnormalities are initially present at night when the patient is supine, which increases the load, and drive is physiologically reduced. Etiology: chest wall disorder. The commonest chest wall disorder causing chronic respiratory problems is kyphoscoliosis, which is often idiopathic, cause unknown, but can be caused by or associated with neuromuscular disease, muscular dystrophy, poliomyelitis, cerebral palsy, and Friedreich's ataxia. Vertebral disease, osteoporosis, osteomalacia, tuberculous spondylitis, neurofibromatosis, and vitamin D-resistant rickets. Disorders of connective tissue, Ehlers-Danlos syndrome and Marfan's syndrome. Thoracic cage abnormality, thoracoplasty, empyema. Other causes of significant chronic chest wall disorder include fibrothorax, following pleural disease such as caused by hemothorax, tuberculous empyema, or asbestos exposure, and ankylosing spondylitis, usually in association with additional lung disease. Diaphragmatic paralysis. Paralysis of one or both hemidiaphragms, often called eventration of the diaphragm, is a common clinical finding. A leading cause of unilateral phrenic palsy is open heart surgery, with an incidence of 2 to 20%. The left side is most commonly affected, but right and bilateral involvement are not uncommon. Thoracotomy, pleurectomy, and pneumonectomy are generally not accompanied by the risk of phrenic nerve injury, unlike mediastinal and esophageal procedures. Other causes of phrenic nerve palsy or diaphragmatic paralysis are shown in Table 39. Clinical presentation. Chest wall disorder. Common. Dyspnoea on exertion, orthopnoea, and symptoms of nocturnal hypoventilation, morning headache, daytime somnolence, and mood or personality change due to associated sleep disturbance. Less common, acute respiratory failure and cor pulmonale. Diaphragmatic paralysis. The clinical manifestations of diaphragmatic paralysis depend on the severity of the weakness, whether it is unilateral or bilateral, the rapidity of onset and the presence or absence of any underlying respiratory illness. Unilateral paralysis, 50% of patients may be asymptomatic. Others complain of dyspnoea at rest or exertion, cough, fatigue, and chest wall discomfort. Some may complain of dyspnoea on lying with the paralysis side down. Bilateral paralysis. This is almost always associated with severe symptoms, particularly severe exertional dyspnoea and orthopnoea. Ventilatory failure, cor pulmonale, atelectasis, and pneumonia are frequent. Due to the respiratory dysfunction in the supine position, sleep disturbances are common, and during rapid eye movement, REM, sleep, when generalized hypotonia is present, ventilatory function is seriously compromised with nocturnal hypoxia and hypercapnia leading to daytime somnolence, morning headaches, and anxiety. Physical signs. Look in particular for evidence of respiratory failure, cyanosis, carbon dioxide retention, flap and dilated veins, and cor pulmonale. Skeletal rib cage deformity, including surgical scars, phrenic nerve crush. Diaphragmatic movement, with the patient lying down, does their abdomen move out, normal, or in, abnormal, when they breathe in or sniff? Investigations. FBC, polycythemia due to hypoxia. Arterial blood gases, ABG, daytime hypercapnia. Early morning ABG, 7 a.m., reflects nocturnal gas exchange and may reveal hypercapnia with acute respiratory acidosis, pH less than 7.35. ECG, signs of right ventricular hypertrophy. Pulmonary function, may show a restrictive pattern. CXR, may be impossible to interpret in severe scoliosis. Spinal radiographs can be examined to determine the Cobb angle, an angle of less than 70 degrees seldom being associated with respiratory failure unless there is another pathology. Overnight pulse oximetry, may reveal severe nocturnal hypoxia. Sleep study, may reveal hypoxias occurring during REM sleep. May reveal the presence of obstructive sleep apnea syndrome in obese patients. Thoracic ultrasound, can be very useful to assess diaphragmatic paralysis. Normally on sniffing the diaphragm moves downwards, but a paralyzed diaphragm or hemidiaphragm moves upwards. Treatment. General measures. Avoid smoking, treat any underlying obstructive airway disease, pulmonary rehabilitation, chest physiotherapy, and immunization in patients with recurrent chest infections. In cases of obesity, weight reduction, and treat the underlying obstructive sleep apnea with nasal continuous positive airway pressure or dental devices. For more details on the treatment of respiratory failure. Chest wall disorder. Surgical correction of thoracic cage deformity does not seem to be of much benefit, excepting to prevent worsening of curvature in children who are still growing by spinal stabilization. Diaphragmatic paralysis. Unilateral paralysis does not require any treatment as the symptoms are usually mild. In bilateral paralysis, most patients will require some form of ventilatory support. Diaphragmatic pacing may be an option in those with an intact phrenic nerve and diaphragm muscle. Complications. Atelectasis, frequent chest infections, type I respiratory failure, type 2 respiratory failure, pulmonary hypertension, and cor pulmonale.